So when we look at the guidelines and what they actually recommend, the CBTI we'd mentioned, sleep hygiene, always important to have as a recommendation. In general, these are the recommendations that guidelines support. So first, CBTI. Okay, and this has been shown to improve quality of sleep, decrease severity of insomnia, improve symptoms of fatigue during the daytime, increase total sleep time, and just improve someone's relationship with sleep. So that's a level B evidence, pretty good. Mindfulness-based stress reduction treatment as well for chronic insomnia, also a B level of evidence. Now, when it comes to medications, medications are considered effective. They will get people to fall asleep, but the long-term use is discouraged in a lot of cases. And part of that is because you're not restoring the relationship with sleep in the same way. There might be some other underlying conditions that are being kind of masked by using sedating medications to help people fall asleep. There's also recommendations to try to avoid some of our traditional hypnotic or sleep promoting medications like benzodiazepines and Z drugs like Ambien, Zolpidem, or Lunesta, right? But they absolutely are used pretty widely. It should not be the only therapy, even if you do have medications on board. And certain medications that are honestly frequently prescribed but are considered poor when it comes to risk versus benefit are antipsychotics. So medications largely like Seroquel, for example. If someone is an older adult, if they have insomnia or they're agitated or experience difficulty in sleep from delirium, it's recommended to try to avoid first line those medications that are considered hypnotics, which include the benzodiazepines and the Z drugs. So medications are within these groups. Okay, so we have medications that can help different aspects of sleep challenges. If someone has difficulty falling asleep, the medications listed up in the top left are the ones that are specifically recommended and approved, with the exception of melatonin, which is over the counter for sleep onset. Okay, so difficulty falling asleep, melatonin, Ramelteon, which is similar to melatonin, triazolam, which is a benzodiazepine, and zaleplon, which is a non-benzodiazepine receptor agonist, or a Z drug, as we call it. If someone has both difficulty falling asleep and staying asleep, then we have a couple more options here. So we have a few of those Z drugs, S-zopiclone, Zolpidem. We have the benzodiazepine tamazepam, and then we have these orexin products. So those are orexin antagonists, daridorexant, lemborexant, and suvorexant, which we'll talk a little bit about as well. For sleep maintenance, so just staying asleep throughout the night, but not necessarily improving ability to fall asleep, doxepin in low doses, which is a type of antidepressant, is approved. If someone specifically has difficulty with middle of the night awakenings, the thing we have to be worried about is how long that medication stays in the system. And there's a formulation of Zolpidem, which is the same drug that's in Ambien, that is sublingual, goes under the tongue, that is approved specifically for middle of the night awakenings, which is neat. Drugs that are used frequently but not recommended specifically just for treatment or management of insomnia: gabapentin and pregabalin, which are anti-seizure medications but are also used for things like neuropathic pain. Amitriptyline, which is a tricyclic antidepressant that's also used sometimes for neuropathic pain, also sometimes used for migraine prophylaxis. Mirtazapine or Remeron, which is an antidepressant. Nortriptyline, which is also a tricyclic antidepressant, and trazodone, which is its own kind of type of serotonin antagonist and reuptake inhibitor. So it modulates which serotonin receptors are specifically activated. Talk more about that in depression side of things. The mechanism isn't quite as important for these products here because they're not really recommended. So moving into the actual products, talk about benzodiazepines in this section. So benzodiazepines work by binding to a GABA receptor. And GABA, remember, is a CNS depressant, right? So it binds not at the site that GABA binds to. It actually binds at its own kind of special site that increases the frequency that GABA receptor is open. So it's a chloride channel. It increases that frequency and it helps people feel sleepy. So it turns on sleepy. Okay. These ones listed here. This isn't all of the benzodiazepines, but the ones listed here are FDA approved for insomnia. Okay. They improve efficiency, sleep onset latency, sleep quality, total sleep time, and wake after sleep onset. However, the harms long-term in particular might outweigh benefits depending on the person. Now, as we talk about in other spaces, too much sleep is bad. Not enough sleep is also bad for both mental health and physical health concerns. We want to try to keep in mind that this, similar to alcohol, will suppress that deep sleep, right? So it affects sleep architecture. So the thing we see in EEG, it can cause dependence and tolerance. So over time, the sleepiness someone experiences from a benzodiazepine dissipates. It decreases. But we also see the body physically become more used to having it on board, especially if someone's taking it more throughout the day. So if someone's taking a short-acting benzodiazepine a couple times a night, this is not as much of a concern. But if someone is taking significant doses for a significant amount of time, then people will have a harder time tapering and discontinuing the medication. There's also risk for things like drug interactions, especially with other sedating medications like opioid pain medicines. And there are associations with things like cognitive impairment, increased risk of dementia. It does make it more difficult for people to recall things and remember things, even just in that short term, and can decrease the breathing drive in the brain while you're asleep. So if someone has sleep apnea, it can worsen sleep apnea. It can worsen potentially depression because it is depressing the activity in the brain, and it can make effective treatment of post-traumatic stress disorder less effective. It has a boxed warning, so it's the little box that's on the actual insert of the package, right? The paper that medications come with for risk of abuse, dependence, withdrawal, and that risk in particular with opioids. Now, these are like I said, the approved benzodiazepines. There are more that are available that are approved for other indications. Sometimes you'll see other benzodiazepines used for sleep, but here we have astaxanthin, flurazepam, temazepam, triazolam, and quazepam. Really, temazepam is the one I see most often. We don't use a ton of the sleep-specific benzodiazepines anymore, but they do certainly exist. Now, moving into our NBRAs, or non-benzodiazepine receptor agonist, we have ezapicolone, zaleplon, and zolpidem. Okay, like I had mentioned before, these are sometimes referred to as Z drugs. They're all FDA approved very specifically for treatment of insomnia. Now, they work very similarly to benzodiazepines, but they don't bind to the exact same site on the GABA receptor. Okay, and they don't seem to have the same anti-seizure and anti-anxiety effects that we see with our benzodiazepines. Biggest side effects we see with this, very similar, right? Things like sleepiness, potential for abuse, the risk of withdrawal if used for a long period of time. It's also important that patients are aware that they should take the medication only if there's a full night of sleep that's available. So if they have to wake up in 4 to 5 hours, that medication is going to still be in their system and they can be impaired. If someone takes it with food, that's actually going to make the medication take longer to start working. So usually, a few hours after dinner, right before someone goes to bed, is when it's recommended to take these types of medications. Now, a unique adverse effect or side effect that we see with these products is what we call complex sleep behaviors. And we do see that. I've had plenty of people who've experienced this. It's oftentimes just things like sleepwalking, but people will sleep cook, sleep eat, sleep drive, sleep whatever. And if that does happen, it's recommended that the individual does not continue to take that medication. So it's important for them to be aware of that. Now, I do want to take a moment and mention the sedating antidepressants, and then we'll move into other products. But for our sedating antidepressants, most of them are going to affect the basically the activity and availability of norepinephrine and or serotonin. Okay. These can be useful, but it's more in the case of using the medication to your advantage when treating depression. So if someone has depression and they have difficulty sleeping, then using a sedating antidepressant could be a clinical consideration. So products like our tricyclic antidepressants, which usually aren't used first line for depression because of potential adverse effects. So amitriptyline, certain doxepin, however, the lower dose that's not an antidepressant, too low, can be used. That's Silanor, that's doxepin. For sleep maintenance, the rest are off-label, right? Not FDA approved. Mirtazapine, paroxetine or Paxil, which I typically do not recommend. It has a lot of side effects. In addition to the sleep promoting effects, it has some significant drug interactions. It's just not our best SSRI by any stretch of the imagination. And then trazodone, which although is an antidepressant, is often clinically used to help with sleep. Again, not a high recommendation, but it is something that you will see people do to help treat insomnia and try to avoid some of those controlled substances like zolpidem, like temazepam.